it's 6 o'clock. It's time to get started. So, good evening, everyone, and welcome to Discovering Opportunities for Change. I'm John Kerwin, Executive Director here at Pennington Biomedical, and it's great to welcome you here this afternoon and evening. So thanks for sharing your time with us, and I hope that it will be time well spent. Tonight, I am honored introducing Dr. Rob Newton. He is head of our Physical Activity and Ethnic Minority Health Laboratory. And Dr. Newton conducts research designed to promote physical activity to address health disparities. And so he's going to discuss ways to use community resources here in Baton Rouge to achieve those goals. So we're hoping that you will leave here with more insight into what is available right here in Baton Rouge to improve your health. And there's going to be time at the end of the session for questions and answers, and we look forward to hearing your thoughts as well as hearing Dr. Newton's thoughts on how to best accomplish these goals. So without further ado, Dr. Robert Newton.
How's everybody doing this evening?
Very good.
Good. All right. So I'm going to talk a little bit tonight about accessing community resources to improve your health. Obviously, we can't access all the community resources, so we'll talk specifically about some of the ones that I have accessed in my time here at the Pennington Center. But before I get started, I always think it's a good idea for the crowd to know something about the presenter. So I'm going to talk a little bit about myself here for a second. Where's the... Sorry, I'll just use it. All right, so who am I? Well, let's see. I was raised in East Texas. So I was raised in New York, and New York was far too cold for me, so I decided to leave and went to Hampton University in Virginia, and enjoyed that time there, but it still wasn't warm enough, so I had to keep on a little bit further south. Ended up in Florida. So if anybody's an LSU fan, I'm sorry, but I am a Gator to the end. Okay, we didn't lose anybody, that's good. All right, so I've been at the Pennington Center for about 17 years now. Came here as a postdoc and kind of worked my way up through the academic ladder, and have enjoyed it here and don't have any plans on leaving, so this may be the first of many different presentations here. But anyway, I should say shame for myself, for the title that you guys got was using community resources. And so I don't use community resources. I try to work with the community. I don't want it to seem like the research that I do, we're sort of fleecing the community. We just kind of come in, take resources, and leave nothing back. So throughout my talk, I'm going to try to let you know kind of some of the things we've done, some things we've left with the community, and some of the results we found. All right, so I'm going to talk a little bit about the health issues that I particularly am interested in, and we'll talk a little bit about what are community resources, what I mean by that term, and then we'll talk a little bit about the interventions and which community resources we've used and some of the outcomes of some of those studies. But I want to go through a little bit of a background first so we can sort of lay the foundation for help you to understand why we did the particular studies that we did. Okay, so in presentations, I kind of hate to just sit here and talk all the time, so I like crowd participation. Okay, so this is your first opportunity to participate. So my question is, what are some of the leading chronic diseases that we have in this country right now? Just raise your hand. Yes.
I mean,
That's true. What's another one? Hypertension. Cancer. Heart disease. Okay, so when I put the slide together, I put it together in order of what I thought you guys would say first. Okay? So clearly I was wrong, because I thought you guys were going to say obesity first. But anyway, so yes, obesity is one of the leading chronic diseases that we have. You guys mentioned some of the other ones. So certainly diabetes, and then heart disease in the form of hypertension and also strokes, okay? And something that you guys maybe are not thinking of, but is a growing chronic disease in this country is dementia, okay? And so dementia is there's many different dementias. One of the leading ones would be Alzheimer's disease, okay? So Anyway, these are some of the chronic diseases that we address in my lab. Okay, so I tend to study health disparities. Okay, so what is a health disparity? It's basically when one portion of the population experiences a disorder or condition to a greater degree than does another portion of the population, or compared to the general population, okay? And so you can define sort of health disparities research very broadly. It's basic, it's clinical, it's epidemiological, but the goal really is to try to determine the etiology of these disorders and what causes them, what sorts of preventive measures can we take, how do we treat these disorders that have a higher prevalence in one population or subpopulation than another. And there are different categories of health disparities groups, and they can be based on where you live, so rural versus urban. Rural environments tend to have more prevalence, higher prevalence of chronic diseases than other areas of the country. And if you are lower SES, you tend to have a higher risk of developing chronic diseases. And also if you're an ethnic minority, it could be African Americans, Hispanic Americans. My research typically focuses on African Americans, and so that's what you'll see throughout the presentation, but this is basically the research that I do. And, so let's talk a little bit about some of these disorders and look at the prevalence rates. So this is hypertension. Okay, and as you can see, African American men and women have a higher prevalence of hypertension across 3 different years of assessments of the NHANES essentially. It's a large epidemiological study that's done by our government. And you can see that the rates, first of all, that they're increasing for many different groups. And you can also see that just overall the prevalence rates, African Americans have prevalence rates above 35% versus the other groups that you're looking at, including white men and women, and Mexican American men and women have rates lower than 35%. If we look at diabetes, we see the same sort of thing. Okay, with African American men and women having higher rates, and then if we look at specifically within, those were just examples. I mean, I could go on and on about stroke and cancers and other sorts of things, but let's look specifically here at Louisiana, and here rates of obesity are higher for African Americans, 42% versus about 32% for other groups. And then if we look at hypertension, it's the same thing, and if we look at diabetes, again, it's the same thing. And what you'll also notice is that here in Louisiana, if you compare the rates of those conditions in Louisiana compared to the NHANES, the national data that I showed you, the rates for Louisiana are much higher. Okay, so it's especially a problem here within Louisiana. Okay, so what are some of the causes of these health disparities? Okay, so one of the major causes, access to healthcare. Okay, so if you don't have access to healthcare, you tend to go to the doctor later. You're in a higher level of disease progression, and that relates to higher morbidity, higher mortality, getting other disorders, and then death. Genetic factors play a role. Your socioeconomic status plays a role. Culture, your views on going to the doctor and accessing healthcare. So there are some cultures who, they tend to view healthcare, traditional healthcare, as sort of the last resort. And other factors come into play beforehand. So talking to your friends and prayer and other sorts of things that come before accessing healthcare in the traditional sense. But another factor is lifestyle factors. So how much sleep we get, and what do we eat, and of course physical activity. So what we do know in African Americans is that there's a lot of literature, some report literature that shows that African Americans have lower levels of physical activity. Okay, and then another bit of literature that shows that lower levels of fitness, or African Americans have lower levels of fitness. And why is this important? Because your physical activity levels, and especially your fitness, are related to chronic disease. So the lower levels of physical activity, lower levels of fitness, you're at risk for developing the chronic diseases that we talked about. So if we look at objective data, in other words, if we put on devices called accelerometers on people, and we let them walk around and do their normal activity, we're not doing much activity. Okay, so if you look at 10-minute bouts that are supposed to be 10 minutes of physical activity, you see that men on average between the ages of 20 and 59 get about 9 minutes, and women, they get 7. Okay, that's pretty low. This is daily. Okay, and if you do it in terms of when you get older than 60, really there's really no time that you're spending doing physical activity. on average. So these lower levels of fitness contributing to chronic disease, and we have federal guidelines that tell us how much physical activity we're supposed to be doing, okay? So, can anybody tell me how much physical activity we're supposed to be doing every day? 30 minutes of cardio, yes, aerobic activity. Okay, what else? Stumped you. We're supposed to get stumped this early. All right, so yes, you're supposed to get 150 minutes of moderate to intensity, moderate to vigorous intensity, or 75 minutes of vigorous. But the other thing that you're supposed to do is you're supposed to get 2 days of strength training. So you should do muscle strengthening activities 2 or more days a week. Okay, so this is actually the federal recommendation. It's not just aerobic. Most people know aerobic, but there's actually 2 parts to our physical activity recommendation. Okay. So if nothing else, I hope that people learn something from this portion of the talk. Community resources. Let's talk about what community resources are. Anything that can be used to improve the quality of community life, okay, or an organization that is designed to improve the quality of life of the community that you live in. Okay, so I'm going to give you some examples of community resources. Okay, so your Chamber of Commerce is a community resource. Big Brothers Big Sisters is a resource. Volunteers, people are community resources. Golden Diners Club, for older individuals, Crime Watch, the Ottoman Society, political groups, YMCA, your Parent-Teacher Association, all these are examples of different community resources that we can access in order to improve our health one way or the other. Okay, so I have done a few studies that have utilized community sources, and one of the community resources that we've utilized is on this list. Mr. Winters, you cannot answer. Anybody else, can you guess which resource we used in our studies?
YMCA.
Yes. Very good.
We have 3 of us.
Exactly right.
We actually all met at the YMCA.
Oh, okay. Sorry. Perhaps I should have excluded more people from that.
He told me not to answer.
All right, so yes, the YMCA. So why the YMCA? Why would we want to access the YMCA for somebody who does physical activity research? Well, it's pretty obvious because the YMCA is set up to promote physical activity. It has facilities, which people need. It has machines, so you can do aerobic exercise, you can do strength training, which means you can do the recommendation if you have access to YMCA. It has experts, so they have personal trainers who can help you. The YMCA also has multiple locations, which is good. So you can go to YMCA's if you live out in North Baton Rouge, if you live in South Baton Rouge, East, West, doesn't matter. There's YMCA all over the city. Okay. So we used the YMCA in a study that was called ARTIS. Okay. And so the point of this study was to do an exercise training intervention for African American men. Okay. Why do we target African American men? Because African American men have high rates of diabetes. And there's very few studies that have looked at exercise training specifically for African American men. So in terms of other ethnic groups, they've done studies, but not with African American men. So we really didn't know what was going to be the effect of doing the exercise training. In addition, nobody had really looked at what happens if you do exercise to the level of the current federal guidelines. Okay, so this study, we kind of got this funded about the time that the new federal guidelines came out. So we looked for African American men who were sedentary at the time, who were not doing a lot of physical activity, and men who had were between 30 and 75 years old, and who were at risk for developing diabetes, which means that they had a family member, nuclear family member, mother, father, brother, sister, who had been diagnosed with diabetes. Okay, but they themselves could not have diabetes. This was a preventive study. Okay. So the men were randomized into 1 of 2 groups. You either got the exercise intervention or you got the healthy living intervention. Okay, so the healthy living intervention, we essentially provided you with information on how to live a healthy lifestyle, but we didn't provide you with any strategies. Okay? But if you got the exercise training group, we wanted you to exercise to the recommendation. So you had to come in 3 to 5 days out of the week, and you had to spend 150 minutes doing aerobic exercise on a treadmill. And then we had a variety of strength training exercises that we wanted the men to do 2 days out of the week. The other thing that we did was we let the men work with a personal trainer at the YMCA. Okay, so the personal trainer helped them to get started, monitored their activity throughout the study. Okay, they met with their personal trainer once a week. So, let's see what we found in the study. Fitness, which again is very important because low fitness levels are associated with chronic disease. So what we found here is that these are the men in the healthy living group at baseline, and then at week 10, this is actually not week 10, it's actually week 20 at the end of the study. But nonetheless, you can see that their fitness levels didn't change, okay? If you look at, from here to here, but if you look at the men who were in the intervention, the exercise training, here they are at baseline, okay, and then here they are at the end of the study. Okay, so there's a significant increase in fitness for these men, whether you're looking at total body mass, or if you're looking at it in terms of just their lean muscle, okay? So an increase in fitness, which is very important. Then, body composition. So here we're looking at waist circumference, okay? Waist circumference really is a measure of your abdominal obesity, and of course, abdominal obesity is related to chronic diseases, so this is a very important measure as well. And what you see here is that the control group, or the healthy living group, didn't really change that much, but you saw a 2 centimeter decrease in the intervention group, okay? And so that's a significant decrease, not just in terms of statistics and numbers, but that kind of decrease reduces your risk of developing diabetes, okay? So that's a significant change as well, meaningful change. And then, how well was the pancreas functioning? Okay, so essentially what this graph is showing you is that the pancreas is becoming more efficient. It's working less, but it's still getting rid of the same amount of sugar in the system, okay? So we're able to show that effect as well. So the pancreas obviously is involved with insulin and sugar, and obviously too much sugar, too much insulin it's a bad sign. So anyway, we were able to successfully work with the YMCA and with these gentlemen to increase their physical activity and reduce the risk for developing diabetes, or at least the risk factors for developing diabetes. And so, again, we didn't want to just kind of go into the YMCA and strip them of all the resources and then leave. And so, some of the things we provided the YMCA obviously was financial compensation. So we paid for all the men's memberships during the 5 months. And we also paid for the personal trainer to work with our men. Okay, so YMCA basically had guaranteed money coming in through the study. The other thing that it helped was for them to have a more supportive relationship with Pennington. Okay, so we've actually continued to do studies working with the YMCA. And the other thing that when we first went to the YMCA and said, hey, we want to do the study, they said, this is great, sounds wonderful, but you know, our personal trainers don't really know much about behavior change. Okay, and so we trained all of their personal trainers on behavior change strategies and motivational strategies, and how to keep the men in the study, how to motivate them when they were having low levels of motivation. Okay, so we provided their trainers with some strategies. Okay, so let's move on to another community resource. But does anybody have any questions before I? Nope. Okay. So another community resource is the church. Okay. So what happens at church? Okay, people, various spiritual beliefs, whether it be Protestant, whether it be Jehovah's Witness, whether it be Mormon. You go to church to worship a higher power. Okay, and while you're at church, typically people pray, typically people are worshiping, singing, and praising their higher power. And the church has been an integral part of the African American community. Okay, so it's been a place of refuge. It has been a place of information. It has been a place of political action. It's been a place of health promotion. And so we wanted to access the church here in Baton Rouge to promote physical activity and to promote dietary change. And so we did a project called Lean. And so what happened, we had developed a lot of relationships through recruiting African American men and artists. We developed a lot of relationships with churches around Baton Rouge. And so we went to them and we said, well, you know, before we basically recruited, now we want to actually do an intervention. And so we asked churches if they wanted to be involved in this intervention. And we actually had 8 churches across Baton Rouge that wanted to be involved. And essentially, this is a translational study. And what I mean by that is that there was a study that was done many, many years ago called the Diabetes Prevention Program. Has anybody heard of it? Okay, so some people have. So what this program really did was it took people who were at risk for diabetes and it gave them a behavior change strategies. So they learned how to eat better, they learned how to exercise more, they learned how to reduce the sugar in their diet. And what happened was that these people ended up with a 58% reduction in their risk for developing diabetes. Okay? So in order to take that from the academic setting and make it into a community setting, many people translated it by essentially developing it and running the diabetes prevention program out of churches. Okay? So we followed that model. We had volunteers from the church, we trained them on how to deliver the diabetes prevention program. We gave them basically materials. We cut down the materials because the diabetes prevention program is like 24 sessions out of 6 months, which is a lot. So we cut it down to 10 sessions. And the other thing that we did in this program is we gave them text messages. So we sent text messages to the participants to remind them of what they learned, to motivate them, to prompt them to eat better, to exercise more. Okay? So what did we learn in this study? Well, it was a weight loss study. So the goal is for the participants to lose weight. And so what you see here is that, so these are the people who were in the control group. This is actually showing the change over the course of 6 months. And so you can see that there's very little change for people who are in the control group, but the people who are in the intervention lost 1.5% of their weight, of their body weight, okay? So clinically significant, like meaningful weight loss is about 3%, so we're about half of that, okay? But again, we're a translational program, not the actual diabetes prevention program. And then in terms of percent body fat, you can see that those who were in the control group, they actually increased their level of body fat. We were able to basically maintain the level of